Hi, everyone. If you've ever been fascinated by true crime or mental illness, then this live stream is for you. Today, we'll chat with an expert about the links between mental illness and violence, as well as a true case. Make sure to stay until the end to hear about these topics and for the opportunity to have your questions answered live. My name is Monica, and I'm the host of Psych to Go's Ask an Expert series. Today, I'm honored to be joined by Dr. Daz, who is our expert consultant forensic psychiatrist. Welcome, Dr. Daz.
Hello, pleasure to be here.
Lovely to have you. Thank you so much for your time. I thought I would just give a brief introduction to me and then to you, so then the whole community can get to know us a little better. So, my name is Monica, and I'm a Psych2Go team member who is passionate about making psychiatry accessible for all. Today, I'm joined by Dr. Daz, who is a consultant forensic psychiatrist and an expert witness. He has personally assessed hundreds of patients in prisons, secure locked psychiatric wards, and courts across the UK. He also hosts his own video podcast, A Psych for Sore Minds, which is linked in the description box below for you to see after the stream. Welcome, Dr. Daz, and thank you so much for joining the whole Psych2Go community.
It's an absolute pleasure. Hello, every Psych2Go viewer out there.
Let's begin by hearing more about the wonderful and interesting work that you do.
So when we talk about forensic psychiatry, there's kind of two different assets to it. There's actually assessing people for their court cases. So if somebody's accused of committing a serious offence, anything from arson, sexual assaults, all the way up to murder, and they have a mental illness, schizophrenia, depression, then I'm the person that assesses them to see whether they're criminally culpable or not. And then the other part of it is rehabilitating patients. So patients who are so unwell, they get diverted to secure psychiatric units instead of prison. We make them better over the space of years, and we reintegrate them into society.
Yeah, and I noticed that you do talk about your work on your channel. Would you like to tell us a bit about the podcast you do as well?
Yeah, I'd love to. So I've got a YouTube channel called A Psych for Sore Minds. It's been going for about a year so far. I release videos twice a week, so I've got over 100 videos there. Sometimes I talk about like high profile true crime cases, but I give my own kind of psychoanalysis. Sometimes I talk about individual diagnoses. Sometimes I talk to like ex-patients or people who have experience of mental health issues, like people who've been sectioned before, or I interviewed a police officer who developed post-traumatic stress disorder through his line of work. So there's lots of different bits and pieces. There's something for everybody on the channel. Check it out.
Of course, and it's available in the description box below so everyone can conveniently have all the links in one place after the stream. Let's begin, though, today by talking about or addressing the questions that were sent in via the YouTube community tab and the Psych2Go Discord. The first most common question is, what is the link between mental illness and violence? Sorry.
That's a big question, and I could literally talk about it for hours, and there are like textbooks this big written on it. But if I was to summarize it down to its basic elements, I would say that there's the most obvious direct links. So when symptoms drive offending. So for example, what I see very regularly is people with schizophrenia. So they have hallucinations like hearing voices which command them to commit violence, like to attack random strangers, or delusions like paranoid delusions, which cause them to kind of preemptively strike out. I think I should make it really clear that I don't want to be adding to the stigma of mental illness, and that this is exceptionally rare. It's only a very small cohort of people with mental illness who commit violence. In fact, people with mental illnesses are much more likely to be the victim of crime. But those are the people that I see, the ones that get diverted to the criminal justice route. So those are the direct kind of causations. And then there's the subtler indirect links. So we call them confounding factors. So the things that lead to mental illness often lead to offending as well. So things like poverty, drug abuse, homelessness, being the victim of violence or sexual abuse as a child, all of those things can lead you to psychiatric hospital potentially, or towards prison. And then finally, there's the kind of subtle, even more subtler links that are maybe not as obvious to people. So, for example, some people who have chronic mental illnesses are quite vulnerable and they get exploited. So I've seen dozens of cases of young men, and it's usually men, who either have like a learning disability or a chronic mental illness like schizophrenia, and they're isolated, they're marginalized, they don't have friends, they don't have a support network, and they're preyed upon by like drug dealing gangs, for example. So these people befriend them, pretend that they're part of the gang, but they actually exploit them to go and do drug deals and to take all the risks. So those are some of the many kind of connections between mental illness and offending.
Right. I really appreciated the point where you mentioned about the stigma and really emphasizing that it's a really small kind of um, proportion, I would say. I think a term was like it's a very small but clinically significant risk or increased risk compared to just the general population.
Yeah, absolutely. So it's a small minority, but as you say, they potentially can be very dangerous. So the units that I work in, the locked forensic units, there are not that many beds. So compared to like general adult psychiatric beds, but they tend to be a lot more well resourced. Patients stay in for years, 3, 4 years. About a third to a quarter of our patients are in psychiatric units for more than 10 years. So that kind of gives you the idea of the fact that it's a small number, but they're really mentally unwell. They have these really strong illnesses that are really treatment resistant. They need high doses of medication. They need a high level of observation, but proportionally, they're a very small group. Yeah.
Right. So if we break down the question further between the links of violence and mental illness, specifically on the violence aspect, how do you typically begin to um, assess a defendant who might be facing some criminal charges?
Well, as you'd probably guess, there's a lot of people who try and fabricate or fake mental illness to try and get a psychiatric defense. So it doesn't happen all the time, but you have to be aware of it as a forensic psychiatrist. So the first thing I do before I even assess the patient is I look at all the available information. So I look at the general practice notes, I look at any psychiatric records, and then I look at the case papers. So the case papers typically have like CCTV footage, or there might be witness statements of somebody who's seen this mentally ill person commit violence. There might be other like police interview transcripts. So there's a lot of objective evidence about what they were like at the time of the offense. Then after all that, I actually assess the patient in person. So for a criminal trial, they're often on remand, which means they're already in prison, or sometimes they've already been transferred to a psychiatric unit and they're on remand in that psychiatric unit. And then if you have low level offending, they're on bail. So I'll see them usually in a solicitor's office. So I assess them in person, and I basically try and match their symptoms, what they're reporting versus the objective evidence. And I pull out the symptoms, I come up with a diagnosis. But obviously just having a diagnosis isn't enough. When I give evidence as an expert witness, the most important question for the court, for the judges, is that person criminally responsible? So that's the main decision I have to make. Were they in control of their actions or not at the time?
To what extent do you work with other professions such as lawyers to come up with this, or is this truly just something that you work within your own kind of healthcare sphere?
That's an interesting question. So I think the thing about forensic psychiatry is it's quite separated, even isolated from other mental health services. So our secure units, for example, are on different hospital grounds. There's a high level of security from high fences to locked doors. So our system is kind of separate from the rest of mental health system because we have to do things like go to court and give evidence. And also some of the legalities are different. So we detain people, we section them under the criminal sections of the Mental Health Act as opposed to the civil sections. So I think we are disconnected to a degree, but we also sort of have outreach. So we help other people. So for example, if you're a general adult psychiatrist and you have somebody on your ward and there's a high level of violence and you just can't contain it, so you can't get that person better through your combination of medications, or there's not enough observation, there's not enough manpower to restrain a person who's violent, then they refer to our services. So to answer your question, we work independently, but we reach out and we help the other people when their resources can't contain violence or aggression.
Oh, I see. Right. That makes sense. In terms of the mental illness aspect of the question, again, for people who just joined, between violence and mental illness, you mentioned schizophrenia being one of the more common kind of disorders that you see. Are there any other types that typically come up in your practice?
Yeah, so basically, schizophrenia is quite rare. As you might know, about 1% of the
Yeah.
population suffer from schizophrenia. Other illnesses like depression, anxiety are obviously far more common. Depending on what measurement you use, you could say that 20-30% of the population, especially the prison population, have those kind of illnesses. But crucially, generally people are in control of their actions when they have a basic kind of depression or anxiety, whereas the psychotic disorders like schizophrenia, and I'd class schizoaffective disorder into that category, bipolar affective disorder, which is, as you might know, where people have periods of depression and then periods of mania. So although the mental illnesses that I see are relatively rare in the population, they tend to be the more severe ones that cause violence and offending. So absolutely, on your average psychiatric secure forensic ward, I would say that most, probably up to 3/4 of the patients have some sort of psychotic illness. Yeah.
Could you tell me a bit more about your experiences working at, I think you mentioned Broadmoor Hospital, and then how is that different from in clinic or when you did your training?
Sure. So I did work at Broadmoor Hospital, although I should say that I was there about 7 years ago as a special interest. So I only went in once a week. I wasn't based there for a long period of time. But Broadmoor, as your viewers might know, is a high secure hospital. So most of the work I did is in medium secure hospitals, but to extend my training, I worked in Broadmoor for a little while. And yeah, it's a fascinating place. The level of security is astronomical. So it's kind of secluded in a place in Berkshire. There's big metal gates around. Even to get in, every single member of staff every single day has to go through airport-like security. There's sniffer dogs, there's patient searches. The ward is set up to decrease the risk of violence, so there's no sharp objects. The furniture, for example, is sort of heavy set and it can't be picked up or used as weapons. You don't have bits of glass, you don't have like metal cutlery. So those are the kind of levels of security. As to how it's different in other places that I've worked, well, obviously the patient group are far more dangerous, because to even get into Broadmoor in the first place, by definition, you have to be the highest risk type of psychiatric patient. And the therapy is really slow. So people in Broadmoor are usually there for many, many years. So as a psychiatrist, the dynamic is slightly different with Broadmoor patients, because you know them intimately. You see them on a daily basis, day after day, for many, many years. You get to meet their family. You pick up on slight different changes of their mental state, compared to where I did other parts of my training before I did forensics, like in general adult wards, where the prawn beds is so high that the turnover of patients is much quicker. So you kind of patch them up, for want of a better phrase, and get them out the door as quickly as possible in these general adult units, simply because there's such a high need for beds that you just about get them better so that they're ready enough to function. Whereas the Broadmoor patients are very dangerous potentially. So you have to do a really thorough, slow rehabilitation so that once they're finally released, they should be safe in society.
To my understanding, some of the things or services that forensic psychiatrists provide include therapy. They work with interdisciplinary teams like OT, PT. They give medications. They hopefully, I think, reduce risk of substance misuse, since that often comes up. Um, are there any other things? And if so, what are typically thought of to be the most helpful for a patient's well-being?
Yep. So good question. So I'll basically summarize the rehabilitation journey. So when somebody comes into one of our secure units, the most important thing to do initially is to medicate them, because you can't really succeed in therapy if somebody's psychotic. If they're
Mhm.
delusional, if they're paranoid, if they're hearing voices, then they're going to struggle to engage in your therapy. So that's the first and foremost. And generally speaking, there are exceptions, but generally speaking, the patients that we see are the illest. They have the most severe treatment resistant types of psychosis. So we have to trial lots of different types of medication, sometimes combinations, sometimes at higher doses. So typically it might take six months, a year, maybe even longer, just to get rid of their symptoms. And then at that point, that's when all the therapy that you were talking about starts. So as you said, we have what we call a multidisciplinary team. So the consultant psychiatrist kind of heads that team and is in charge. And then we'll have usually a psychologist on the team, an occupational therapist, nurses, obviously, and junior doctors. So the psychologist is the person that really sits down with the patient and does the intense therapy. So they'll sit down with them typically at least an hour a week, sometimes group therapy as well. And it will be tailored to that patient's needs. So you said yourself, often a risk factor is drug and alcohol use. So part of the therapy will be rehabilitation. Then there might be relapse prevention. So if you're psychotic, you don't necessarily know that you're becoming unwell. You lack insight typically. So you believe these paranoid thoughts, you believe the voices you hear are real. So it's about teaching the patients to recognize them in the future. For example, having a trusted family member who if they tell you that you're relapsing, even if you don't feel it, you have to kind of trust in them. And then after all that, we do occupational therapy. So almost all of our patients, unfortunately, come from deprived kind of environments, poverty, lack of job opportunities. So it follows that if you just deal with their psychiatric symptoms and then you discharge them, then you're just putting them back into the same environment. So they might relapse, they might reoffend. So you're setting them up to fail unless you give them intense occupational therapy. So that might be education, sending them to college courses, online courses. Sometimes they don't even have basic literacy and numeracy, or setting them up with a vocation. So that might be voluntary work. A lot of these units, they have like a coffee shop on site. So they train up some of their patients to become baristas or waiters. So just to give them an opportunity to kind of live a pro-social life. And then after all of that, we start testing them on leave. So if a patient is sticking to their boundaries on the ward, they're not getting into sort of arguments or fights or beefs. And bear in mind that a lot of these patients come from prison. So there's that kind of prison mentality on a lot of the wards, not in everybody, but in a majority of the patients. And then you test them on leave, initially in the hospital grounds, then out in the community for a short period of time, escorted with a nurse, and if that goes well, unescorted for short periods. And if they stick to the boundaries, come back on time, not coming back drunk, not going out and committing crime when they're on leave. If they do all those things, then over a long period of time, you give them more and more freedom and independence, and then eventually you discharge them. So that, in a nutshell, is the therapeutic process. As I said before, it takes years usually to complete.
Are all those factors, like giving them more and more responsibilities, a part of your assessment for reoffending, or are there any other aspects that go into this assessment?
So assessing risk is what you're talking about, is a
Yeah.
core part of what a forensic psychiatry does. So some of those things are definitely relevant. So if I was going to break it down for your viewers, I would split it into three kind of segments. There's the historical risk, the current risk, and the future risk. So historical risks are things that can't be changed, but they help inform us of somebody's risk of potential violence. So I mentioned some of these before as confounding factors, but like a history of previous violence, a history of antisocial peers, like, a criminal family, or being a member of a gang, drug and alcohol use, poverty, having a versatile criminal background. So somebody that's involved in lots of different types of crime. Those are all things that increase risk of a person committing violence in the future. As I said, they can't be changed. They're just the baseline. Then there's the current clinical risk. So to answer your question, that's absolutely what I was just talking about. So it's their behavior on the ward. Are they engaging in therapy, or are they just going through the motions? Do they have like a criminalistic or violent attitudes? Do they have misogynistic attitudes for people with a history of domestic violence? How's their response to medication? Are they willing to take their medication? So those are all the current risk factors. And then finally, especially when you're thinking about discharge, you think about risk factors for the future. So that's things like, what environment will that person be returning to? Will they have a stable house or accommodation? A lot of these patients don't have family ties, so they're sent to these like observation hostels. Do they have a job, as I mentioned before? Do they have family support? How well do you think they will deal with stress in the future? So you know from somebody's history if they become very aggressive when they're challenged, or if they relapse on drug and alcohol. So if they've done it in the past, then there's a risk they'll do it in the future. So you look at all these kind of risk factors, some historical, some dynamic, which means they're changing, and you get a big complicated picture of somebody's risk profile. So that's the bread and butter of what a forensic psychiatrist does.
I imagine it must be especially challenging when dealing with patients who present with APD, like antisocial personality disorder, and those with psychopathic traits. Do you have
Yeah,
any examples of what you normally do? Or before that, would you mind giving a brief summary of APD for our viewers who might not know, and then going into that discussion?
sure. So antisocial personality disorder is very common in the patient cohort that we see, especially in hospital. So not the ones I necessarily see at court, but the ones who've made it past court that go into secure units for long-term rehabilitation. So very briefly, in case your viewers don't know, a personality disorder is like an entrenched flaw in your character, as opposed to a mental illness, which is like a period of being unwell. So psychosis that I talked about is a period of being out of touch with reality, whereas a personality disorder is entrenched. So antisocial personality disorder is when somebody lacks empathy, they don't care about the law, they don't care about the rights of others, they don't learn from their mistakes, they're generally aggressive, and they're generally impulsive. They might often take drugs, and they have a pro-criminalistic lifestyle. So as I'm sure even just by me saying this, you can imagine that they're a nightmare. They're a nightmare to interact with, to deal with. Psychopathy is, I like to think of it as like the older brother of antisocial personality disorder. So it's all of those things and more. And psychopaths tend to be very manipulative and cunning and deceitful. So somebody with antisocial personality disorder is often aggressive and overtly in your face, whereas a true psychopath is a bit more crafty than that. So they might commit severe violence, but they won't. They're very good at hiding it, and they see everybody else as an opportunity to somehow exploit. So even people that they're close to, even friends and family, they will see them as an opportunity to take advantage of at some point. So to answer your question, what it's like to deal with them on the ward, well, you kind of get used to it, but it's not that all patients like this by any means, but at any given ward at any given time, I'd say at least half of the patients have an antisocial personality disorder. And there's a lot of alpha males on the ward, so there's often arguments, bickering, there's fights, not very frequently, but certainly not unfrequently. So when I was working in a medium secure unit, we probably have an incident on the ward on average every probably 2 or 3 times a month. And the way that you deal with it is you have to be very strict with your boundaries. So if you give them a little inch, then often they might try and push it. So for example, if I give somebody leave, they have to come back on time. And if you let them get away with coming back for 5 minutes late, 10 minutes late, then it can lead to a slippery slope where they're pushing those boundaries because they try and get away with more. Or they might make the odd sexualized comment towards a nurse that's sort of borderline flirting. If you don't call them up on it, then they will learn that they can push boundaries and it will get worse and worse. So you have to be very strict with your rules. So if they come back late for leave, then leave is stopped for 2 weeks. And then it's reinstated as long as their behavior's okay at the time. And you do get pushback, as you'd expect. You get people who get very aggressive. Being shouted at is part and parcel of my job. You know, I've been punched in the face before. Again, doesn't happen very often, but it does happen. But the other thing is that they know that they're being assessed in the long term to be discharged. So despite their intention, their kind of internal personalities and their impulses, over time they learn to control them, because they know that if I swear at this doctor, if I make this comment at this nurse, then my leave is going to be stopped. Then it's going to add an extra month, 2 months, 3 months to my detention in hospital. So it's kind of a bit of a cat and mouse game where they cooperate, sometimes because they have to and they feel pressurized, sometimes because the actual therapy is working, and sometimes a bit of both.
If we break that down even further, how do you tell whether they're just kind of participating in the therapy sessions, for example, or like saying that it works, sort of like malingering in the sense of that, just because they know that that's what they have to do. And then when they eventually get released, then there might be risks to themselves or others. How do you really balance all of that?
Very good question. So I guess the answer to that is a couple of things. Firstly, you can only really use the evidence in front of you. So somebody can stick to all the boundaries, they can go through all the therapy, they can jump through all the hoops. And from a humanitarian point of view, you can't really detain them indefinitely. Not only is it unfair on that individual, but also it clogs up the system and there's more people that need to come in from prison. So you have to take a risk. And all you can do is judge the risk assessment with the information you have. And, you know, I'll be the first to admit as a forensic psychiatrist that sometimes people go out and do reoffend. I'd say around a quarter to a third of our patients eventually reoffend, not necessarily immediately, but within 2-3 years. And you have to accept that as part of the job. And sometimes they don't intend, they're not necessarily faking the therapy. And at that time, they are trying to engage. And at that time, they're sticking to the boundaries. But the thing is the environment of a secure ward with nurses and doctors is obviously very different from outside, where they've got their friends, they've got, you know, sometimes childhood friends who commit burglaries and robberies, and they've got access to alcohol and drugs, and they've got access to victims. So sometimes just the temptation of being out with all these destabilizers is enough to destabilize people. And the other thing that I would say is that, as I mentioned before, we look at their behavior on the ward. So it is relatively easy for somebody who is antisocial, for example, to pretend that they're listening in therapy and to say all the things that a therapist wants to hear. That's not hard to do. But what is harder to do is to live on a ward for 3 or 4 years where you've got these other people who are pushing your buttons, who are doing whatever to annoy you, whether it's playing their music loud or being rude towards you or making comments. So the point I'm trying to make is that if they're able to contain their emotions and their anger for a long period of time, then by definition, the therapy is kind of working. Whether it works outside in the community, you have to take a level of risk and you have to see further down the line to a degree.
Do you normally do any follow-ups after they've been released back to society? And what does that normally look like?
Yeah, absolutely. So I've mainly worked in my previous reincarnation. So right now I just work for criminal courts, but in the past I've worked in a medium secure unit. So it wouldn't be me personally that would follow them up, but there would be like another forensic psychiatrist who works in the community who only works outside. So they don't work in hospital. And what they do is they give them regular appointments. So the patient has to come along, have their mental state checked, has to take their medication. Sometimes that's in the form of an injectable depot antipsychotic. And they have to meet up with their nurse regularly. As to how frequently or how intense that is, it kind of depends on the situation. So if somebody seems to be sort of living up to their responsibilities, as far as we know, isn't committing violence or, you know, is going to their job. And if people like the hostel staff don't report any problems, then their level of supervision can decrease. So they might be seen like once a month. Then if they're stable, once every 2 months, once every 3 months, and eventually are discharged to a general adult psychiatrist. However, if somebody's being really kind of aggressive and violent and there's just risks that you're kind of semi-aware of, like you think they might be taking drugs or they've got a vulnerable person with them, like a new partner, for example, then obviously you have to have a higher level of support. And if you think they're really unwell, then you might have to section them back into hospital.
Yeah, so you mentioned the point of the social influence and how it can kind of unfortunately push them back into their behaviors that could potentially be dangerous. So I'm wondering, to what extent does therapy often involve, the more, I think it was like relationship-based therapy as opposed to things like cognitive-based or acceptance and commitment-based, those kind of things?
Yeah. So it's completely tailored to the individual. So if somebody's had a history of violence against a specific group, so if they've got a history of domestic violence or of like racial violence, then the therapy will be targeted directly at building up relationships. So challenging their misogynistic views or challenging their kind of antisocial attitudes. Whereas if somebody has a history of violence that's completely random because, for example, they have schizophrenia and they're hearing voices, then you don't need that level of therapy. So it's kind of tailored to the individual. But unfortunately, even with our best intentions, even with our occupational therapy, even with sending them to hostels, there's not enough resources to give everyone a perfect life. So to a degree, there's always going to be some social destabilizers out there after discharge.
Right. I'm also quite interested to know on this topic of like the legal aspects of forensic psychiatry, the concept of plea of not guilty by reason of insanity. I'm sure like the community has tons of questions about this. I do as well. What is involved in this? What typically does it look like? Is it normally like what people see in movies kind of thing?
Depends on the movie, I guess. Yeah, so the insanity plea, not guilty by reason of insanity, is a psychiatric defense. So it's a full psychiatric defense, and it can be for any offense. But the bar is set quite high. So what you need to do is you need to get a professional forensic psychiatrist who acts as an expert witness, and they assess the defendant, and they do all the things that I was talking about before. They look at the previous medical notes, they look at the psychiatric notes, they talk to the individuals, they talk to prison guards, hospital staff, etc. So they get a picture of what that person's mental state was at the time, case papers, CCTV footage, etc. And the legal criteria are really kind of specific. So I won't say them all because it gets a bit dull, but the crux of it is whether, first of all, they've got a mental disorder that's caused a defect of reason. And if either they didn't know what they were doing, or if they didn't know that it was legally wrong. So if they were so unwell that they literally didn't know that they were lashing out at somebody, say, for example, they believe that person didn't exist or that person was a demon, or if they didn't know what they were doing were legally wrong. So if they, in their delusional state, genuinely believed that their life was in danger, then they and so they didn't think they were committing a crime, then they will get the insanity defense. So you need to have evidence given by a forensic psychiatrist. And as I said, the bar's quite high. So the number of cases where I'm asked to consider that defense is relatively high, but the number of cases where I actually think they meet that bar is actually relatively low. And if you like, I can give you a case example where,
yes, that'd be
I found
great.
So I've actually made a video about this quite recently on my channel. So I think probably my most emotional and shocking case that I've had in my career. It's very sad, so a bit of a trigger warning for your viewers. So it's a real life case of a very young lady. She was 18 years old, who I assessed. It's probably about seven or 8 years ago now. And she had no kind of history of mental illness, no delinquency, never got in trouble with the police, came from a very hardworking migrant family, no history of drug and alcohol use. And out of the blue, she became psychotic. So I think this happened over the space of several weeks, very gradually. And she was babysitting, and she smothered and killed her 2-year-old nephew. And at the time, she genuinely believed that she was ridding him of demons by smothering him, and she believed that she could reincarnate him straight afterwards. And obviously, when the family found out, they called the police and she was arrested. And when she was in the police station, she had all this bizarre kind of behavior, like she was eating tissue paper when people weren't watching her. She wet herself at one point. So I assessed her a couple of months after this, when she was in prison on remand, obviously. And she was very kind of guarded, very evasive. I found out years later that she was extremely paranoid, but it was really hard for me to pull out symptoms of psychosis because she wasn't telling me what she was thinking, or she wouldn't talk about the offense to any great deal. So I transferred her over to the female medium secure ward that I was working in at the time, and I had to give evidence at the Old Bailey. So I even though I couldn't get much from her, I used the witness statements and I interviewed the family members thoroughly to get an idea of what she was saying, what she was doing on that day, and also in the weeks leading up to the killing. And I got this picture that she was actually psychotic. She had a number of bizarre beliefs. So I gave evidence, and that's exactly what I was talking about. So not guilty by reason of insanity. And so I gave evidence on behalf of the defense, and then the prosecution and the barrister aggressively cross-examined me and tried to kind of knock my confidence and tried to undermine me. But luckily the judge listen to my findings. So she got the insanity plea. Obviously, that doesn't just mean there's no consequences, but it does mean that legally speaking, she's not guilty of that offence. But then she went back on a hospital order for long-term rehabilitation on the female medium secure ward. And after many years, she eventually got better. Her psychosis improved with medication. And then after about 18 months, because her psychotic beliefs had gone, I think the reality of what she did actually seeped into her consciousness. So she understood that she'd taken her nephew's life. So as you would expect, she got extremely depressed. So she had to have a whole new set of therapy, other types of medication. There was like family therapy with her older brother, who's the father of the child that died. So that was part of the therapy as well. So for me, that was just such an interesting case. I mean, it goes without saying, it was a horrific incident. It was very emotionally charged. Not just for what she did, but also speaking with the family. But as an educational point, it was a real eye-opener for me, because it's the first time I'd given evidence at the Old Bailey, first time I'd had a successful plea of not guilty by reason of insanity. So yeah, the whole process was emotional, but really educational as well.
Yeah, I can't believe that it all happened, or her psychosis seemed to all happen within the span of a few weeks. Like as soon as you said that, that just like caught my attention. So presumably you had to look back to see like her whole like life history, and like nothing was there, or nothing
Absolutely.
indicated.
Yeah. So psychosis gradually comes on in the space of months. And I do think that she had some indication. So I think she had what we call in psychiatry a prodrome. So it's not fully psychosis, but it's kind of quasi-psychotic sort of odd beliefs. So for example, she would tell her family to stop watching smut on TV, even though they were watching the same kind of sitcom that they always watch. She started listening to this weird chanting instrumental music instead of her usual pop music. She would make odd comments, like she would say that she believed the sky was painted on a really tall ceiling. So definitely bizarre thoughts, but obviously nobody could have predicted what would happen. And I think her family were just hoping that she was going through a phase. They had no idea that she was becoming mentally unwell. So yeah, it was a tragic case. There was no indication that she would end up killing a child, but there was some indication that her reality was unraveling.
Yeah, early detection is always better, right? So, to what extent, as a forensic psychiatrist, do you work with people who are, for example, experiencing prodromal schizophrenia, or just developing symptoms of depression? You name the mental disorder, essentially.
To be honest, the answer is very little. We have almost no contact with people, because by our specialty, we pick up people when they're already in the criminal justice system. So the earliest I will see somebody is when they're coming for their very first court case. So that there is a system in place to pick up early symptoms of psychosis and neuroses, but that's more the general adult psychiatrists, or even the family doctors like GPs. Forensic psychiatrists only see people who have committed serious violence. So by then, they've already gone past that point of no return.
I see. Yeah, I really learned a lot today. I feel like from the beginning, and then the process, and then what happens after. Thanks for sharing your insights on these.
Absolute pleasure.
Before we finish, I'd just like to ask whether you'd like to share anything, tell us a bit more about any upcoming podcast episodes or things that people can look forward to.
Yep. So I recorded a bunch of videos today. I'm just trying to remember what they were on. So I tend to pick out high profile true crime cases. So I talked about Joseph McCann, who is this man who's just horrific. Even as a professional, I can't think of any other words to describe him, but a monster. He went on a killing spree in 2009. A sexual assault spree in 2019, I believe, and he had 11 victims altogether. Started off in London, went to Watford. So in my video, I'm psychoanalyzing what his background was like. There was a lot of trauma, a lot of antisocial behavior. So I've got a video on that. Recently on my channel, I've done some videos more about criminality. So, for example, how polygraphs work, how police use specific interview techniques to try and pick up liars, and yeah, a couple of other high-profile cases. My probably the most interesting one, I think, on my channel is about Andrea Yates, who is again a tragic case. So she's a nurse who in 2001 in Houston, she became psychotic and she killed her 5 children. And the reason it's so interesting, apart from the offense itself, was because the medical legal process was really convoluted, and I think there was a lot of mistakes that were made. So initially she was charged with murder because of the bad evidence by one of my peers, an American forensic psychiatrist. And then a couple of years later, people found holes in the evidence he gave. So she got retried, then got a finding of not guilty by reason of insanity, which we were talking about, and then ended up in psychiatric prison. And I think her case echoes the one that I was telling you about, Yasmin, that 18-year-old girl. So it's always kind of struck a chord with me. So that's one of my most interesting videos, if your viewers want to check it out.
Yes, thank you for sharing. So, in sum, we did talk about the links between mental illness and violence. We went into a bit of depth about those, and we ended on a couple of very interesting cases, and finally talked a bit about your wonderful podcast and your videos. So, thank you so much for your time today, for joining me. I appreciate it a lot.
Monica, it was an absolute pleasure. I'd love to come back on one day.
So thank you to the Psych2Go viewers for your time. Let us know what you thought in the comments. Check out the links and have a wonderful day.
Bye-bye, everybody.